We're back with Dr. Ricucci, and we're going to get back right into the question. So, you know, what they say is that you get progress when you mix someone's passion with their profession, and it seems to me like you've managed to do that, and your histology work is a good example of that. We've had an online conversation previously before on the role of coronal leakage in terms of apical failure. So I know that you believe that it's not as big of a factor, but where do you think it's not? Clearly, if it's bacterial base and you don't have seal on top,
this
that could be a problem.
was another controversial topic. You may remember that in the 90s, one paper every 4 in International Endodontic Journal and Journal of Endodontics was dealing with coronal leakage, because we were convinced, we, including me, that it was a very important factor for failure. But more and more, it became clear that it is not true. I mean, coronal leakage does exist, no doubt. It is possible, but in optimally prepared and filled root canal, this is not a relevant problem. Once again, I think that I am responsible for that, because I could demonstrate in cases extracted in teeth no more restorable, because the crown was totally lost and caries was in direct contact with gutta percha. Those teeth were extracted, and I went to analyze in all the segments from coronal, middle, and apical third. And in all these cases, even when the caries has been in contact with gutta percha for years, that infection was in the first millimeters coronally, not in the apical portion. So I'm not talking about treatment made by a general dentist. I'm talking about treatment performed at a very high level, technical level. It takes a lot of time for bacteria to reach the apical part. So on the contrary, I have to release the confirmation for what I am telling you. Studying, analyzing for histology all cases that fail, even cases with optimal coronal restoration. Then you have the root teeth. And what do you find? That the reason for the failure is infection somewhere in the apical canal, including ramifications, sometimes extraradicular infection. So this is the real reason for the failure, the presence of bacteria somewhere in the apical portion of the root canal system. So I think that we can abandon the idea that coronal leakage is a common reason. It may be the reason when there are spaces, voids between the root canal filling and the wall. Then obviously this is a highway for bacteria to go down, but it is not a common factor.
I mean, it may end up being the so-called perfect storm of having multifactorial problem. Well, all these factors align, and all of a sudden coronal leakage becomes a problem, but it's not necessarily an issue. The same way, you know, an open margin on a crown is not always going to cause, you know, thermal sensitivity and problems, and would take a long time. And in some other cases, you know, it's immediate. So I guess multifactorial problems always should be addressed that way.
Let me add that leakage is a big problem when we do vital pulp therapy, but this is a different leakage. You don't need to have leakage through the canal. Leakage from the margin of the restoration until the pulp tissue. So it could be direct capping or partial pulpotomy or whatever you want, then restoration must be perfect. Because bacteria may leak immediately the pulp wound in the chamber and cause pulp death.
I think we agree that most of the problems here are at the apex. So if you were to give advice for the most critical factor of being able to clean the apex adequately, what would be your advice?
This is another good question. Well, I would say that we have to accept today, realistically, that we have around 10% failures. Everybody, including me, including you, in root canal treatment. And that depends exclusively on the preoperative condition, preoperative biological and microbiological condition of the root canal, of the apical canal, because it's a matter of time. Many of the cases with periapical lesion that we treat, they do not have full necrosis all along the canal, but they have necrosis reaching the middle third, sometimes the apical third, but the most apical pulp sometimes is vital. Vital means that there are no bacteria, there is no infection there. And this is the reason why we have a very high success rate, reaching 90% or sometimes more. But in time, it's a matter of time, and when necrosis and bacterial colonization reach the apical ramifications, irregularities of the root canal wall, then there is no way, because we treat the canal. We use ultrasonic, sonic agitation of the irrigant solution, but they cannot reach distant areas from the main canal.
Right.
And this is why we fail, despite the techniques that we used.
And just to be clear, in terms of failure, what would you define as failure? Would you define symptoms? Would you define non-regeneration of the full PDL? Would you define survival? Because that's another big important topic too. And if we can't, because we say 90% success, for example,
yeah.
What is that? Is that regeneration?
Yeah, now you're opening another discussion. You're opening the can, because we make the distinction between loose evaluation criteria and strict criteria. I tend to apply strict evaluation criteria, which means, as you said, absence of symptoms, but also the radiographic appearance of a lamina dura around the entire perimeter. So these were the original Strindberg criteria, which are always valid today. On the other side, you have a patient when there is a residual radiolucency, the pain is not sensitive to percussion, everything is normal, it works normal. You may call that functional teeth. I can accept this definition, but the problem is, in order to maintain a residual radiolucency, there must be bacteria somewhere. In small numbers, but they are there. So I think that properly we should inform the patient, because the patient can tell you, well, I don't have any problem. Why do you want to do apical surgery here? And I agree with you, but you have to know that you have infection, and no one can tell you whether this lesion will blow up tonight or in 10 years or until your life. But the reason, certain fact, is that there is some infection somewhere in the canal. If we inform the patient, we are okay. Then the decision is held by the patient, not by us.
No, clearly, you're absolutely right. But do you then think that apical surgery is an integral part of the overall endodontic continuum? Because in certain cases, you said it's just not going to be possible to completely clean it out.
Apical surgery is a fantastic tool in the hand of a specialist, in the hand of an endodontist, and it is just the continuation of the orthograde treatment. Apical surgery may finally solve the problem, because I just told you about the limitation of our root canal treatment, because we cannot reach distant areas. So what do you do with apical surgery? You physically remove the apical portion when there is the concentration of ramifications. Sometimes bacteria are on the external profile of the apex. If you do surgery, you are removing this, but there must be the right indication. So apical surgery should never be a shortcut. So whenever we can, we have to access the canal, retreat when you can, and so on. There are precise and specific indications for apical surgery to work.
Then that is true, and I always say that is the main reason why apical surgery did not have a good success rate in the past, because it was used as a panacea. But now our understanding of the indications have increased our ability to do better diagnostics with the 3D imaging and finding out whether the problem is only apical, as you mentioned, or it's inside the canal, yeah. In which case now we can really have a much higher success rate with apical surgery. So, Dr. Ricucci, I know you're busy and you have a presentation coming up in a few hours. I really appreciate your time and your expertise, but just one last question. Where do you think the future of endo is headed? Is it we're going to go into a more biological solution to the problem of endodontic infection, or do you think it's a problem that's going to get solved by technology and material science? What do you think?
Well, I think that we need both. I cannot imagine a future in endodontics and in dentistry in general if we do not improve our knowledge about bacteria, for example. We need to know much more about bacterial life in the canal. We need to know what bacteria species are more able compared to other species to cause the pathology and so on. This is extremely important, how we can control infection, but at the same time, I believe that we will need new technology in the future. because the technology, techniques, and machines that we have today are not enough to completely remove infection from all the part of the canal. We can treat canal, some minor ramifications, some irregularities, but we cannot go so far. So I expect, I'm not against technology. I really trust that in the future there will be someone inventing a fantastic machine which can kill bacteria and remove necrotic tissue from irregularity. This is our challenge in the future if we want to really increase our success rate.
Yeah, without a doubt, I think the future is going to be exciting and interesting. The goal, obviously, is to save teeth, and hopefully a combination, as you mentioned, of understanding and science and technology could come together and help us improve our success rate. Dr. Ricucci, our distinguished endodontist scientist coming to us from Italy, and you know everyone's looking forward to your presentation this evening and tomorrow. From my residents, I know they've all been really excited to be there to listen to you speak. And I want to thank you for spending your time with me.
Thank you, Dr. Nash. It was my pleasure to be here.
To seeing you more often here in Boston. Terrific. For Rubel Dindo, I'm Ali Nasseh, and until next video, let's save some teeth.